Bismillahirrahmanirrahim. Assalamu alaikum. Welcome to the channel. This is exam season, so from today we will start a series of questions which will include the multiple choice questions from different segments of the subject, and then we will try to cover the SEQs as well. So let's start today's discussion. Today we will try to cover MCQs from external ear. So you are requested to like, share and subscribe the channel so you are not going to miss any further presentations. So we know that external ear is composed of auricular pinna and external auditory canal. So auricle, it develops from the 6 tubercles which appear around the first branchial cleft during intrauterine life at which week. So I will give a pause for a few seconds for every question so that you can assess yourself and guess the answer, and then you can assess yourselves how many questions you replied rightly. So here it is the 6th intrauterine life that they are what we call as hillocks or tubercles of His. There are 6 tubercles which appear around the first branchial cleft, and these tubercles, 3 from first arch and other 3 they arise from the second branchial arch, and each hillock it forms distinctive portions like hillock 1 is forming the tragus as you can see here, and hillock 6 will form the future antitragus. But as you can see here also in the picture, that lobule is not derived from these hillocks. So external ear is more caudal initially than the lower jaw, but with the development and growth of the lower jaw, it places the external ear in relatively higher and more vertical orientation. So hillocks, they appear around the first branchial cleft, but itself they are the cartilaginous tubercles which arise from the 3 from the first and other 3 from the second branchial arch. Then external auditory meatus, it develops from first branchial cleft. Length of the external auditory canal, everyone must be knowing that it is 2.5 centimeter or 25 millimeter or 1 inch. And we know that the external auditory canal, it is composed of cartilaginous portion and the bony portion. Cartilaginous portion forms the outer 1/3 of the external auditory canal, and this cartilage is continuous with the cartilage of the pinna. So if total length of the external auditory canal is 24 millimeter or 25 millimeter, 1/3 will be 8 millimeter. So cartilaginous portion is 8 millimeter. So naturally it is smaller than the bony portion. And the reverse question will be that the bony part, it will be larger than the cartilaginous portion. Other options which are available here, that of course this is larger than the cartilaginous portion. It contains ceruminous glands, contains hair follicles. No, because the skin which is lining the cartilaginous portion or outer 1/3 of the external auditory canal, that skin has got the adnexa which will include these hair follicles and ceruminous glands, while the skin which is lining the deeper part or the bony part of the external auditory meatus, it is deprived of, or it is devoid of these adnexa. So boil will occur only in the cartilaginous portion, not in the bony meatus, because the furunculosis or the boil, the definition of that one is that it is the staphylococcal infection of the hair follicles. So when hair follicles are not present in the bony meatus, furunculosis cannot occur. So it will be confined only to the cartilaginous portion which contains the hair follicles. So answer here is that bony meatus, it is larger than the cartilaginous portion because it forms the inner 2/3 of the external auditory canal. Bony part of the external auditory meatus is directed. So instead of being confused that what is the direction, just assume that a person or a patient is sitting in front of you and his external auditory canals will be like this. If you bend your index finger like this, so his cartilaginous portion, for example, for this ear, it will be upward, backward and inward, while the bony portion of this ear, it will be again downwards, medially and forward. So this is how you can memorize the directions. So bony part will be downward, medially and forward. So coming back to the question again, you can see, so the answer will be here downward, forward and medially will be the direction of bony part of the external auditory canal, because external auditory canal is not a straight tube, it is tortuous. Cartilaginous portion is going backwards, upwards and medially, while the uh, bony part, it is going downward, forward and medially. Again, the features of bony part of the external auditory canal includes all except it forms the 2/3 of the total length of the meatus. Yes, it is larger than the cartilaginous portion and it is roughly 16 mm as compared to 8 mm of the cartilaginous portion. It has got a narrowing near its middle. Yes, I will come to that in a bit. It is called isthmus. Then its roof is related to the middle cranial fossa. Yes, and it is directed downwards, forwards and medially. Just in the previous MCQ we just learnt about that. So it does not contain the ceruminous glands, because that also we discussed that ceruminous glands and hair follicles, these are confined to the skin which is lining the outer 1/3, that is the cartilaginous portion, while the skin lining the bony part does not contain the hair follicles and ceruminous glands. So here the answer will be B, that is it does not contain. Rest of all are correct regarding the bony part of the external auditory. So just to summarize, that length is 1 inch 25 millimeter or 2.5 centimeter roughly. Outer 1/3 is cartilaginous, which will be 8 millimeter. Inner 2/3 is bony, which will be 16 millimeter. Then posterior wall of the external auditory canal will be shorter than the anteroinferior wall. I just showed you the picture also, and of course it is not a straight tube, as we have seen in the previous slides that cartilaginous portion is going upwards, backwards and inwards, while the bony part, it is going downwards, forwards and medially. So the canal is straightened by gently moving the auricle upwards and backwards to counteract the direction of the cartilaginous portion. In neonates, the bony external auditory meatus is not developed because still the tympanic bone is to develop. So there we have to pull the pinna downwards to make the external auditory canal straightened. So in this picture, if you can see that, for example, if I just highlight this portion, so this is the outer 1/3 which is cartilaginous portion, and rest is the inner 2/3 which is the bony portion, and this is in adults. So you can see that this is the posterior wall and this is the anteroinferior wall. So you can see this anteroinferior wall is longer as compared to posterior wall, so that this is the tympanic membrane. So this is not that tympanic membrane is straight lying at the end of the external auditory meatus, rather it makes an angle of 55 degrees, so it is slanting just because the antero-inferior wall is longer than the posterior wall. Secondly, as you can see, the most medial portion of this antero-inferior part, it is a bit down as compared to the rest of the floor of the external aortic canal, just adjacent to the tympanic membrane. This is what we call as deep meatal recess. Then coming back to what are the narrowings, there are two narrowings in the external aortic canal. One is of course where there is osteocartilaginous junction. So this will be roughly, this will be the part where the cartilaginous portion is attaching with the bony part. So this will be a narrow portion. But the most narrowest part is a roughly 6-7 millimeter away from the tympanic membrane. So roughly it will be somewhere here, just in the middle of the, you can say, of bony part itself. So this is what it is called isthmus, and this is the most narrowest portion of the external aortic canal. So two narrowings in the external auditory canal. One is at the osteocartilaginous junction, and the other one is 5 to 6, some books have written 6 to 7 millimeter lateral to the tympanic membrane, and which is called as isthmus. Another one of the congenital anomalies, there are different congenital anomalies of the pinna and external auditory canal. There can be agenesis, microtia, there can be macrotia. Another condition is what we call as prominent ears or bat ears. So what is absent in bat ears? These are the options: antihelix, concha, helix, lobule, or tragus. Antihelix is absent in the patients which are having prominent ears or bat ears. As you can see the picture here on most left, that there is no antihelix, so that the tympanic, this helix is folded over the pinna, and this pinna has become more prominent, or it is making a wider angle with the skull as compared to a normal ear where you can see antihelix is there, that fold, so that the pinna is not that much prominent. So that's why bat ear is also called as prominent ear. This is due to the deficiency of development of the antihelix. Pinna, you know that there are different ridges and grooves, and we label them as outermost is called helix, then this portion is called crus of helix, the portion which is covering the external aortic canal, this is called tragus, then opposite to tragus is antitragus, and in between antitragus and tragus is intertragic notch. This is a bowl shaped depression which is called as concha. Then helix, opposite to helix is antihelix, which is dividing into two crura, and these crura, they are covering a depression which we call as triangular fossa. And the depression or groove between helix and antihelix, it is called as scapha. Sometimes there is a prominent tubercle like structure present there over the helix, which we call as Darwin's tubercle. So, and this portion below, this is called as lobule, which is devoid of cartilage. No cartilage is present here, but here is only the skin, and fat lobule is present in the lower this lobule. Now, a 30 years old male has developed swelling of the pinna after road traffic accident. He was diagnosed as a case of oral hematoma. Select one of the following. It is the collection of blood between perichondrium and cartilage. It is the collection of blood between perichondrium and the skin. Conservative management is treatment of choice to prevent perichondritis. Tight dressing should not be applied as it causes necrosis of pinna. All of the above statements are correct. Basically, this is the collection between the perichondrium and the underlying cartilage. And as we know that the cartilage in itself is a avascular structure anywhere in the body. So it gets its blood supply from the overlying mucoperichondrium. If anything or any collection between the overlying perichondrium and the underlying cartilage. Cartilage uh, becomes ischemic, and this ischemia can lead to the necrosis of the cartilage. So here the answer is that this is the collection between perichondrium and cartilage. Similarly, in case of nasal septal hematoma, there is collection which is of the blood which is there between the mucoperichondrium and the underlying cartilage. So this is how it can present with, and this one. And as you can see that this is basically the between the mucoperichondrium and underlying cartilage. So it is not involving the lobule, because lobule does not have the cartilage. So here up to this is the mucoperichondrium. This perichondrium is present attached here. So lower limit of this collection of blood is up to the pinna, excluding the lobule. So boil as we just discussed, that this is the furunculosis or boil. It is the staphylococcal infection of the hair follicle, and in case of external auditory canal, we know that the hair follicles are present only in the cartilaginous portion, and that cartilaginous portion is the outer 1/3 of the external auditory canal. So the answer is C, outer 1/3 of the external auditory meatus, because the inner 2/3 is bony part, and the skin there that does not contain the ceruminous glands or hair follicles. Acute severe pain in external ear is due to, again, furunculosis is very painful. There can be pain in other conditions as well, but here acute severe pain is there. Similarly, the commonest manifestation of folliculitis in the external ear is, again, this will be very severe earache. Obliteration of the post-auricular sulcus with forward displacement of the auricle. It suggests, again, the furunculosis, because here the edema is coming from inside the external auditory canal. So from inside it is coming outwards, so obliterating the pinna, and when pinna is obliterated, automatically pinna is pushed forward. Now this table is present there in your books, and you must have read it very thoroughly, because the close rival for this furunculosis is acute mastoiditis, and we have to differentiate it. So there are so many differentiating features between them, but I will come to the one is auricular movement. It is usually painless in acute mastoiditis, but it is painful in case of furunculosis. Then displacement of the auricle. It is only anterior in case of furunculosis. Anterior or forward like this, because there is edema in the external aortic canal which is obliterating the post-auricular groove or post-auricular sulcus. So the pinna is being pushed forward or anteriorly. In contrast to if there is mastoiditis or mastoid abscess, first thing is the swelling will be there in the post-auricular region. So the post-auricular groove will not be obliterated. Rather, it will be accentuated. By the word accentuated means that it looks that this groove is too deep. And secondly, the pinna will not only be pushed forward anterior, but laterally and downwards as well. So this is very different, clinically differentiating feature between acute mastoiditis and furunculosis. So retroauricular sulcus, in case of acute mastoiditis, it is not obliterated, rather it is accentuated, while it can be obliterated in case of furunculosis. Commonest cause of perichondritis is, it is of course trauma. That trauma can be road traffic accident, it can be assaults, it can be sports injuries, but this trauma can lead to perichondritis. Again in the circle you can see that whole of the external this pinna, there is congestion, redness, but the skin overlying the lobule, it is normal. So it shows that this is underlying perichondritis, not the superficial skin infection, because if it would have been a superficial skin infection, it would have involved whole of the skin. But here the lobule is spared or is not involved, because from the anatomy, just we discussed that lobule does not contain the cartilage, while perichondritis means the infection of the cartilage. So only the upper part of the pinna is involved, and there is a clear demarcated line between the infected perichondrium and leading to perichondritis from the normal lobule. Suprameatal triangle, it is also called as MacEwen's triangle. Its location clinically felt through posterior part of the auricle. If you go posterior part of the auricle, there you can feel a small depression on your own skull as well. So that is what it is called, MacEwen's triangle. The boundaries of MacEwen's triangle is that in front is the temporomandibular joint. This is the temporomandibular joint. Then this is the external auditory canal, and above, you know, this is zygomatic line, and it is temporal line going like this, which is separating it from the middle cranial fossa. So superiorly is the temporal line, anteriorly is this external auditory canal, and if we draw a tangent from this temporal line to the external auditory canal, so this becomes a triangle which we call as MacEwen's triangle. I show you it a bit more clear. Now you see, this is a dry skull actual. So this one is, you can see that this one is the temporomandibular joint, and here you can see this is the opening of external auditory canal, and this ridge, very clearly you can see this is the temporal line. From here, this temporal line, if we draw a tangent over the external auditory canal, so this is the MacEwen's triangle, very clearly visible over the dry skull. Again, we can go that this is the temporomandibular joint, this is external auditory canal, and this is the temporal line. From here a tangent is here, so this is the MacEwen's triangle. Then comes the question that what is the importance of this MacEwen's triangle? For which structure this is the surface landmark? So this is the surface landmark for mastoid antrum. So during mastoidectomy, mastoid exploration, whether this is cortical mastoidectomy or modified or radical mastoidectomy, when we are approaching it from post-auricular incision, after, you know, removing the skin, superficial fascia and periosteum, we will, you know, identify this MacEwen's triangle, and we start drilling of the skull from here, because in the depth around about 10 millimeter from the surface, there is what we call as mastoid antrum, which is one of the mastoid air cells. This is single, most permanent, and even in children this is present. So this is a surface landmark for, this is, you can say, the applied anatomy or clinical importance of knowing this MacEwen's triangle. So with that, we come to end for today's presentation. You are requested to like and share the channel, and thank you very much for watching.